Okay, let's spend just a little bit of time talking about how to evaluate images of the chest and bony thorax. And here's an outline of the material we'll be kind of looking at in this lecture. And I should point out that I'm looking specifically at Merrill's, which is the 13th edition, volume 1. So if I'm calling out page numbers, it's from that text. Here's some of the anatomy of interest, and one of the things that's going to be particularly important to us that we'll be looking at quite a bit, of course, is the ribs. So I should point out, of course, there's 12 ribs, and of those 12, the upper 7, or so let's find that Roman numeral 7, these are going to be called the true ribs, right? And the ribs below we'll call false ribs. Let me get this is like ribs 8 through 12. So there's 5 false ribs, 7 true ribs on the superior portion, and of these false ribs, we call them false ribs because they don't connect directly to the sternum. You'll notice they connect up to this costocartilage, right? In the lower 2 of them, rib 11 and 12, these bad boys down here, we're going to call them floating ribs because they don't really attach to anything. Now, on the ribs, it's important to note a little bit of some articular surfaces with the vertebral bodies. So we'll call this area up here the head of the rib, and it has these facets here. There's a number of facets that articulate with the so here these joints on the vertebra, the upper and lower demifacets for the thoracic vertebra. So this view here is posterior view of the rib. So we can see the rib is kind of more horizontal in the posterior aspect. It wraps around, it has a slight angle as it moves towards the anterior portion. And that's going to be helpful to us as we're counting these ribs. So as we're looking at thoracic viscera, right? This is one of the primary views that we'll be talking about. And this, of course, is a PA chest projection. So some of the things that we're looking at as we determine PA, and one of the reasons that we use PA, of course, is increased protection for the patient. We're shielding their thyroid essentially with their body. And one of the main things that we'll look at to distinguish it from the AP is going to be the size of the heart. Size of the heart, as well as the projection of the clavicles. We'll talk about that a little bit more, but just note the area, the proximity of the clavicles below the apices on this projection. So this is page 496 to like 499 in our textbook, and these are some of the things that we're going to use to evaluate thoracic images. So air-filled trachea at the center of the image. The left and right sternoclavicular joints demonstrated free of superimposition or relatively equilateral from the vertebral column, and then equal distance on either side from the vertebral column to the lateral borders of the ribs. One thing I've pointed out a few other places and times is the technologists tend to put their markers face up on the board, and anytime we're shooting PA, that's going to project the marker backwards when we display it for viewing. So you can actually put your marker upside down on the board when you're shooting PA in order to get it to display correctly. And we don't want to see any foreign bodies. We want sharp outline in terms of the image evaluation for exposure, sharp outline of the heart and the diaphragm, and then lung markings. If we can see these fine lung markings throughout, that's helpful. And these kinds of evaluations, I should point out here that as we're doing these evaluations for image criteria, it's helpful to do this because this is going to be the building blocks towards comparative pathology. So what I'm interested in here is for us just to articulate what we're seeing, right? And to just be able to describe positioning-wise what we're seeing. So we are seeing sternal ends, more or less. I see a little bit more of this one on the patient's left than I see on the patient's right. I see air in the trachea, more or less midline. I can see, I'm guessing the vertebral column's right about here, and I have about equal distance from either side. I'm about the level of T7. So I think I'm looking at a PA chest x-ray. You'll notice with minimal rotation. So I point out there's just a little bit of difference between these. Look at how it's diminished the size of the heart, right? So as I describe these things, and then if we zoom in here, we may be able to look at this pneumothorax and kind of point out what it is that we're looking for when we look at a pneumothorax. With a pneumothorax, it's this line right along here, right, where we go from seeing a lot of nice little lung markings to seeing no lung markings. So I see all these nice little fingerings of the lung, and what's happened is there's an air bubble that's trapped within the sac, the visceral sac around the lung, and that air bubble being trapped there, it's depressed the visibility of the lung markings on our image. So let's look at this image together, and I'll give you just a little bit of time to look at this image and just kind of do the paceman thing yourself. Positioning, what are we seeing position-wise? Area, collimation, how's it collimated? Exposure, how's the exposure? And in particular, as we look at the exposure, let me zoom in just a little bit here, because there is something going on in this image, but I don't want it to distract us from important stuff. We see lung markings here when we zoom in there. This would be more apparent if we're looking at it on our image. Considering that area where we don't see any lung markings, but we do see some glob of stuff going on over here, let's talk about this image. So this patient has a right side pneumectomy, right? Meaning the right lung has been removed. So the left lung was overexposed because the right AEC chamber was activated. What are they talking about? We've got AEC chambers, right, inside our board. A lot of times there's a display that looks something like this at the console. The technologists, when they set up this patient for exposure, you notice the marker backwards, they activated these lateral AEC chambers, right? So it didn't cut off the exposure because it had not yet fully penetrated this area of soft tissue inside of the patient's right thoracic cavity. And you'll notice there's a lot more density here than there is over here, right? So it burned out down here because of that. What we need to do is repeat this image and turn this thing off too. We just want this left side AEC activated. Then we're going to get adequate penetration here without burning it out down there. Now, there's no way to correct for the sternoclavicular ends and things like that in this image, and that's what I'm pointing out is as we do these things, we'll start to notice how doing image evaluation allows us to also note some pathology sometimes. Okay, now let's turn to page 500 to 503 in our textbook, and we'll talk about this view. So as we look at this, I mean, this should be pretty obvious that what we're looking at is a lateral projection. So we're going to be looking from costophrenic angles up to apices. We want to see nice superimposition of the costophrenic angles, and in particular, we don't want more than a half of inch between the posterior ribs, the right and left posterior ribs. On the back side of the patient, we want to see the sternum, a nice lateral profile. In terms of exposure, so that was positioning notes. In terms of exposure, we want to see adequate penetration, nice contrast between the heart and the bones. Let's look at this image for a while. Again, we're not going to assume that we know what we're looking at. But positioning-wise, describe what you see positioning-wise. Okay, now the area. How is it collimated? Exposure. Marker. There's a marker present. The aesthetics. And that'd be things like foreign bodies. And then demographics, name stuff. Okay, the big thing that sticks out on this, of course, we've got some foreign bodies up here, these EKGs, but they're out of the area that we're really interested in looking at. And we've got some looks like snaps on a patient's gown. They're also projected free of the area of interest. But the big thing that stands out is we've got a pretty big gap between the right and left posterior ribs. That means the patient's rotating. We can also note that here on the costophrenic angles. Now, it's worth thinking about in terms of magnification, which way is the patient rotated, right? Because it's blurred out a number of other things. The patient's right side needs to be moved posteriorly. How do I know that? Well, I can see this gastric bubble right here. So that's what tells me otherwise, if I did not see that, I would know it was rotated the other way. Okay. This is page 510, 511 in our textbook. This image looks very similar to our PA, of course. So let's zoom in just a little bit. And but we'll notice the heart is enlarged. comparison to the PA. And we see the clavicles projected a little bit higher. So we're looking at an AP image. But we're going to use a lot of the same measurements. We're going to make sure the these clavicular ends are more or less equal distance from the spine, the air-filled trachea in the middle of the spine, and the distance from the vertebral column to the lateral rib margins is about the same, right? All right, so let's take a look at this image and just describe what we see. So P-wise, what do we see? Positioning, the area that's covered, collimation, exposure, how's our exposure, marker. We've got some interesting foreign body type things going on, and some of these have been indicated, but I'll circle a few others. There's something going on there. You can see this here, and then this here going down and like that, coming in from the patient's right arm. And then demographics, of course. So this is an AP, portable chest x-ray, and we're called out to do these quite a bit. And what we're looking at is a CVC, or a central venous catheter. So maybe the PICC line nurse has been in to insert a PICC line, central venous catheter, as well as possibly ER doctor or anesthesiologist has inserted an endotracheal tube, ETT. So we are called in to do these APs quite a bit to verify where these things are situated, right? So let's talk about whether or not we've actually got a good image. And I think the main thing that I look at personally is where the sternoclavicular ends are located in terms of sup to emph. These are getting pretty high, pretty close to the apices of the lungs. So what I know is this is what I would call like a lordotic image, although the patient may not be situated lordotic. For whatever reason, the central ray seems to have been angled, and in this case it was angled cephalically, which pushed those clavicles up towards the apices, up over the apices of the lungs. If it was angled more caudally, that central ray was angled more caudally, we would see the clavicles more inferior, almost more towards the center of the image. All right, let's just describe again what we see, and if you need to, you can turn to page 458, 459 in our textbook. What we're talking about here, whatever this position is, it has projected the sternum free of the vertebral column, and it's also in no way being overshadowed by the heart. We're able to clearly see the entire sternum. And so each one of those things is pointed out in this image over here. We can see the SC joint, and if our marker is correct, that's the patient's right SC joint here, and left one on this side. And then we see here's the manubrium up here, right, and sternal body and the xiphoid process at the bottom. So this is a sternal image, right? That's what this picture was done to represent. And so we know that this position, we call it a lot of times the PA RAO sternum. Okay, and so again, looking at this image and just describing what we're seeing, we see a lot of the sternum. We see the sternum from top to bottom and a marker, and some anterior ribs, sternal body, xiphoid process. So this is a lateral sternum, left lateral sternum. So without knowing, in any way, shape, or form what this position is, as we kind of describe what we're seeing, what position we're seeing, we're able to say, this is a lateral sternum. This is a good skill to have, to just be able to look at an image and start to gauge what this position is. All right, let's talk a little bit about these images. Is this just a bad chest X-ray? We've got looks like two different images of some similar anatomy, both according to the marker of the patient's right side, and so they're correctly projected here. And it looks like these numbers are helping us, they're kind of giving us a little hint here. we've got some numbers along the ribs. And these are ribs, unilateral ribs specifically, upper and lower. So we've got an upper and lower ribs. And so these images were done differently in one critical way, besides the central ray position. They were done, the upper ribs were done on inspiration, full inspiration, which allows us to get normally from like 1 to 9 above the diaphragm. And then the lower ribs are done on full expiration, and that generally allows us to visualize 8 to 12 below the level of the diaphragm, so that they have basically the same amount of contrast between them in the abdominal viscera. And I include this image just to kind of point out that we're going to, anytime we're doing ribs, we're going to need to get some good history from our patients and very specifically say why we chose to do the ribs that we chose to do. So if the patient is hurting more posteriorly, we may do an AP projection, right, in order to capture those posterior ribs that are going to be closer to our image receptor down here. Versus if the patient indicates that they have pain on their anterior surface, we will probably be doing our projection PA, again, in order to get that anterior surface closer to the image receptor. If they say they are hurting more on the lower side, we'll be shooting more low. If they say they're hurting on the upper side, we'll be shooting more high. And a lot of times rib series expect us to do this with the addition of sometimes like a PA and lateral chest x-ray in addition to that. And here are my references. Thank you so much.